All right. Listen, thank you for the opportunity to present these data. Following some great information you received just a little bit ago, let's talk about some of the clinical trial results and then some clinical experience, personal clinical experience, in fact, of mine as well. So, okay. Um, so we know the traditional indications for CRT, and they're there for your reference. Okay, but have a look at the right panel. Of the over 6 million patients with heart failure, 3.1 million people have HFrEF essentially, and you can see the breakdown there with the NYHA classes. And we're going to really be looking at these class 2, class 3 patients, as Bill mentioned earlier. It's really difficult to kind of sort those patients out. And so if you look at the middle panel, we're really looking at these patients that are NYHA class 2, but maybe had some recent 3 that are vacillating between there. Certainly class 3, solid class 3 patients, EFs less than 35%, and on some good GDMT. When you look at that population, you're looking at about 1 million patients there. And, about 30% have a wide QRS or have an indication for CRT. And about 70% up in some certain series, about 70% of patients actually don't have a CRT indication. They have a traditionally narrow QRS. So when you look at QRS, certainly CRT effectiveness can be related to this. And so if you look at the very wide QRS morphologies, you can see on the x-axis there, increasing QRS duration going along the x-axis there. You certainly have increasing clinical benefits in those kind of wide QRS patients. So what that shakes out to is that, you look at patients with a very wide QRS are greater than 150 milliseconds, left bundle morphology, et cetera. It's a class 1 indication. This is not necessarily something that is, controversial. And then, of course, you have 2A indications there is split out the 16% there. And then, our patients with the narrow QRS, there's no real option for these. So this is where we are, I think, heading. So I'm getting a little bit of feedback, and hopefully that's not very disruptive for you there, but let's continue. So the history of device therapy for HFrEF patients is really significant, 34 years. And, what we saw is that basically patients or with narrow QRS, they were multiple CRT trials, and really it's had no impact on mortality, heart failure, hospitalizations, or, any of those patients with narrow QRS really didn't benefit. There were some multiple trials for autonomic modulation and defeat, Nectar, and innovate heart failure as well. They really didn't reach endpoints, and there were some complications as well. Fast forward to 2019, we have Barostim coming onto the scene here with an FDA approval. In fact, it had a breakthrough designation. So really, it's something that we've been looking to try and do for a long period of time. So when we look at the device indications, where typically these patients are class 3 or 2 with a recent history of 3. I like how Bill mentioned that earlier, because I think it's difficult to suss out those patients that are 2 and 3, and as we know, they vacillate between 2 and 3 or any NYHA class really. EF less than 35%, NT-proBNP less than 1,600 picograms. Now, to me, that number, the 1,600, is it's kind of where do these patients get benefit? Not NT-proBNPs of 30,000. They may be sort of where I live in the stage D world, where they need VAD transplant, So something a little bit upstream of that. That's kind of what I think about that 1,600 picogram level. Obviously, they're not indicated for CRT and narrow QRS, as we've been discussing. There's no restriction for atrial arrhythmias, similar efficacy, and we'll talk through that a little bit as well. And, there is some thought that potentially these patients, patients with CRT that are non-responders may actually benefit from it as well. So quick nod to the implant procedure here. You can see a radiograph on the right. Essentially, a small incision is made by an ENT or vascular surgery to access the bifurcation and secure the electrode outside of the carotid. Obviously, this is not an endovascular procedure. A traditional pacemaker pocket is made, and then you tunnel the lead over the collarbone and connect up the system essentially. So, our vascular surgeons are doing this in about 30 minutes, and the whole OR time might be an hour. they typically go home the same day. Now, looking at the trial design for what led to the adoption of BAT is the BHF. Here we can see the trial design here as well. Optimization of the patient. Baseline was established in one-to-one randomization, and you can see this here. And it was really what led to the approval of the device was 6-minute hall walk, quality of life, as we mentioned previously, NT-proBNP, and then obviously a low adverse event rate. So I want to take a second here and really kind of look through this a little bit. This is a very earnest trial. I think this is a very honest trial. We see patients that are in their 60s, good amount of females here as well. You know, most patients are class 3. I think that that's probably appropriate. This is not somebody that's going to be heading towards an LVAD or transplant. You can see the Minnesota Living with Heart Failure scores there as well. What's interesting to me is it's a relatively sick population because you see the 6-minute hall walk of around 300 meters. And, you know, those patients literally under 300 meters, I'm just going to start to think about these patients. Hey, are they going to need something stage D, such as VAD transplant? But if you start looking at things like systolic blood pressure, it's a little bit higher than you might expect for somebody that maybe is moving towards really that stage D situation with blood pressures of 120 systolic. LVEFs, not absolutely terrible. Again, 27, 28 in both groups there. NT-proBNP, again, not 20,000, 700, as you can see here. GFR is reasonable. Of course, we have a narrow QRS. And look at the number of hospitalizations. When we look at this is important, obviously, because this is what leads to sort of the quality of life argument here. Comorbidities are extensive there. I won't really kind of belabor this, but again, it's an earnest trial. Fair amount of CKD, fair amount of diabetes. Again, this is the real world. And you can see that patients are relatively well treated here. So when you start to look at symptom improvement here, the left panel, quality of life, we saw a 14-point reduction in Minnesota Living with Heart Failure, score, which is obviously improvement. Clinically meaningful, we think, is about 5 points reduction. And if you look at the CRT trials, and Bill mentioned these earlier, you see similar kind of situations, maybe potentially numerically more than the CRT trials that mentioned here. And if you look at the 6-minute walk, the exercise capacity, we see a reasonable increase in walk, 60 meters. Clinically meaningful, maybe about 25. And if you look at contact CD here in Miracle, we see almost 40 and almost 30. So again, numerically higher, but certainly the same situation here. And the NYHA class is a similar story here as well, where we have an improvement in NYHA class that's really potentially, again, numerically more so than the CRT. But again, we saw 34% improvement. Okay. Next slide. Something happened. Oh, there we go. Thank you. So, looking towards a little bit more harder endpoints here, we might see here the NT-proBNP reduction, about 25%. Clinically meaningful, again, kind of the 10% relative reduction is important. And this really comes back from some of the things that we looked at from the Paradigm HF trial, which, demonstrated a 10% reduction in NT-proBNP, and that was also associated with a significant benefit in cardiovascular death or heart failure hospitalization. And that's kind of what we're looking at here. As far as BHF, the ongoing, hospitalization and mortality data remains blinded, actually, to support the further analysis. Let's see if I can do this. Next slide again. I'm not sure it changed. All right, and now this is very interesting because obviously GDMT evolves as we move forward in time. So what happened was ARNI was approved during the enrollment of the trial. What happened in the actual trial is that more patients were, randomly added, and Entresto was added to these patients in a higher proportion than the control group. So despite that, we actually saw, despite 4 times more patients getting ARNI in the control arm, we saw these types of improvements. Next slide. Good. All right. And then also there's a signal for reduction in serious cardiovascular events. Again, this is, kind of very interesting to look at. It suggests a reduction, but I think that this is at least good that we know that we're not doing any harm. If you look at arrhythmias, we saw a relative reduction of 50%, angina, 44% reduction in a relative way, and then syncope, presyncope. The nice thing to me is that we're not making patients worse, and there's a signal to better, and then this warrants further follow-up. And of course, from a neurologic event perspective, the 97% MANS-free rate is really, really excellent in this particular trial. Next slide. So I'll just bring some other things here out, across subgroups looking at clinical efficacy. Presence of atrial fibrillation really didn't make a difference. We saw, improvement in both groups in kind of stratifying the ejection fraction, 25 to 35, and then less than 25%. We also saw improvement in both groups, which is, again, very, very reassuring. And then, of course, from a gender perspective, we see improvements as well in all the areas of quality of life, 6-minute hall walk, NYHA class, and NT-proBNP as well. Next slide. So I'm going to belabor this. Let's keep going to the next thing. But I mentioned earlier why the FDA approval occurred with 6-minute hall walk, quality of life, NT-proBNP, and then a preferable event rate. Next slide. This is interesting because this is where I got involved with the trial, with the feasibility trial, Hope for Heart Failure. We saw something similar at that time as well. Again, this is predating BEAT-HF, reduction heart failure hospitalizations, heart failure length of stay down by about 9 days, the 6 months before the randomization to the 6 months after the device. That's important. And then again, similar to the last slide, less in the way of CV events. So that's good. Hopefully that continues. Next slide. So I'm going to keep moving here. I think we talked about this already. This is for your reference. It's how to think about, to use this device in our patients with the narrow QRSs. You can see the stratified with the ejection fraction there, and the NYHA 2 and 3, I think, is important. Next. So looking at some case studies here, we had a 53-year-old male with ischemic myopathy. He had class 3 symptoms, with peripheral edema, orthopnea, exertional dyspnea. You can see his LVEF was relatively low. LVEDD, again, pretty big. Not a lot of blood pressure there to kind of optimize GDMT. In fact, this patient came to us pretty much optimized as well. You can see the 6-minute walk of 340 meters. He was hospitalized twice. Next slide. You can see the GDMT that was there at the time. Barostim was implanted, and patient was sent home the same day, which is typical for us. And over the next 3 months, what we saw was an increase in functional status, decreased loop diuretic dose to achieve euvolemia, and there were no interval readmissions as well. And the blood pressure was a little bit higher, and what that allowed us to do was to, over time, actually increase GDMT in this particular patient. Next slide. Similar patient, 60-year-old female, non-ischemic myopathy, 4 years, a good long time. No other past medical history. She was kind of fit as a person, didn't have a lot of other comorbidities per se, but again, exhibited NYHA class 3 symptoms. You can see the symptoms that are there: LVEF 25-30%, mild RV dysfunction, I should say. Again, the LVEDD was a little bit high, some valvular dysfunction as well. Blood pressure not robust to be able to allow increasing GDMT. Had an ICD, of course, before, and walked 395 meters. She was hospitalized recently. In fact, that's how we got to meet this woman, but she really didn't have any hospitalizations before. She didn't want to be in the hospital. Next slide. You can see her GDMT there. The Barostim device was implanted. Patient was sent home the same day. And, you can see what happened over the next 3 months, but I'll take you to the fourth point. The implanting surgeon called me and said, hey, your patient has lost like 10 pounds. You might need to do something about this. I'm not sure. She's diuresing very fast. I just wanted us to be aware, which we actually have seen quite a bit. And again, these patients, have higher blood pressures, 110/76 at month 3. Heart rate was still reasonable. And we were actually able to increase GDMT in this situation. Next slide. So in summary, 17 years after the approval of CRT, here we have another option. In my estimation, there's a wide gulf between GDMT and I would call small devices, and then things that I do, which are VAD transplant. There's just not a lot of things to do between that if you have a narrow QRS. And I think that this is important. Devices like this are going to kind of bridge that gulf. We also see that this is safe and effective. We have had some interesting comments from our patients that say that, hey, I like the fact that there are no leads in the vasculature or in the heart. And that's an interesting thing that I didn't realize the patient would kind of grab onto. It's not a very morbid procedure. It takes about an hour, maybe even 30 minutes of actual operating time, if you will, and they go home the same day. So again, so the bang for the buck from our patients is pretty good. Programming is very simple, and I think it's payers are actually gravitating towards this. It's becoming easier and easier to put this in, and we've not had a lot of challenges from a reimbursement perspective.